Welcome to CE on ReachMD. This activity is provided by Total CME and is part of our Minute CE curriculum. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
This is CE on ReachMD, and I'm Dr. Marwan Noel Sabbagh. Joining me today is Dr. Dani Cabral. Dani, how should we treat agitation in Alzheimer's disease today, and what approaches are on the horizon?
Well, agitation in Alzheimer's is one of the most difficult symptoms we manage because it is common, distressing, and sometimes dangerous. And we now have a definition of agitation, which is defined as having one of three components, or at least one: excessive motor activity, verbal aggression, or physical aggression. And that has to be going on for 2 or more weeks, along with the cognitive impairment, say in Alzheimer's disease, and it's causing disability in a person's life. And so it's really helpful to have that definition as a starting point. And all medications have been off-label for agitation until our first FDA-approved medication for agitation in Alzheimer's, brexpiprazole, was recently approved. And so we've been seeing benefits with that and more uptake. We found that with 2 to 3 milligrams daily, that can be effective. And that has to be titrated gradually. Like all antipsychotics, that does still carry the box warning of increased mortality. So we need to be aware of that and counsel our patients and families. And so they are shared decision-making on that. Now, there are a lot of exciting things on the horizon and for agitation and treatments, and this is being studied more and a more understanding of the neurobiology. So one example is xanomeline trospium. Now, that's already been approved and used, is being used for schizophrenia. And what makes it interesting in neurodegeneration is that it targets the M1 and M4 cholinergic pathways, which are highly relevant for cognition, salience, and behavioral regulation. And so in Alzheimer's disease, phase 3 studies are underway using this medication for both agitation and psychosis. And then another promising treatment that we're seeing under investigation is dextromethorphan bupropion. So it's exciting. Mechanistically, this is not a traditional antipsychotic. Dextromethorphan acts on NMDA receptors and sigma-1 receptors in the monoaminergic systems, while bupropion helps increase its bioavailability. Now, clinically, phase 2 and phase 3 data for dextromethorphan bupropion suggests improvements in agitation, and it's received FDA breakthrough designation for this. So otherwise, another still under investigation but exciting emerging area is the FAAN, the FAAH-MAGL inhibition, which modulates the endocannabinoid system. So just rather than just sedating behavior, this interestingly intersects with stress signaling, neuroinflammation, and synaptic plasticity, and that helps with emotional regulation. So there's a phase 2 study going on of this dual FAAN inhibitor designed to increase the endocannabinoid tone. And there's the study is called the Balance AAD phase 2 trial, and we are always hoping our studies end up positive, and so we'll find out soon enough. So the way I think about treatment today for agitation is layered and nuanced. So we start with environmental and medical optimization. We use evidence-based pharmacologic options when needed, like brexpiprazole, and increasingly we're looking towards these emerging therapies that are actually targeting the neurocircuitry of what's going on and restoring stability rather than just suppressing symptoms. And this broader shift is for treating agitation as a behavioral endpoint to understanding it as a biologically driven network disorder and not just, again, a reaction to the cognitive changes related to Alzheimer's disease.
That's a lot. Wow. Thank you, Dani. I tell you that because I know and as a practicing behavioral neurologist, I see the limitations of the drugs we have had traditionally. I see the need. I see the driver and the urgency that families want solutions, and they want them pretty quickly. And we see limitations of what our drugs can do. So having new options, new targets, new mechanisms of action is very, very exciting. But at the end of the day, I know I'm going to be ultimately often reaching for pharmacological treatment. So it's better to have more in my toolbox than I have now. I believe that really brings everything together, and thank you for listening.
You have been listening to CE on ReachMD. This activity